Hi everybody, welcome back to another episode of QuickSTEPs. Today we're going to be covering high-yield respiratory questions, how to approach them, how to answer them quickly and efficiently. If you have any content in particular that you want me to cover or something that you think that I missed, please feel free to comment down below. Along that line, feel free to like and share and subscribe to this YouTube channel. It really does go a long way and it really helps me put out more material for you guys. So I assume you guys have already watched the dermatology video and you're familiar with the method. So we're going to be continuing off that, and I don't need to give much of an intro, so we could just kind of delve right into questions. Let's look at question 1. I want you to try to tackle this question using the method that we talked about in the last video. So, we have a 40-year-old Caucasian woman living in a socioeconomically low part of town, found unresponsive in her apartment. They found her in the kitchen with an open gas stove. So what's the whole point of this? She's unresponsive, she has an open gas stove, and it's during the winter time where she presumably would have the heat on. Which of the following conditions would present with a similar shift in the oxygen hemoglobin dissociation curve? The curve basically describes the function of oxygen release with regards to hemoglobin. In a different condition, there will be a different expected level of oxygen dissociation. So what does this mean? This essentially just means if you shift to the right, you're going to have oxygen more readily available at the tissues, hemoglobin will be binding oxygen more loosely, and a left shift would do the opposite. Hemoglobin would bind oxygen very tightly and would not allow it to be released to other tissues in the body. So what causes a right shift? Well, you should know a low pH, also known as a high hydrogen concentration, an increase in CO2, an increase in temperature, and an increase in 2,3-BPG, which is part of the glycolytic pathway. What's the whole purpose of this question? Well, you could attack it two different ways. The first one is looking at the answers and seeing which one doesn't fit. Thankfully, all these answers they give us will either give us a right or a left shift. So we could do out of A through E, which one of the 5 does not match the other 4. Or we could also look at the question and try to implement that. So the question has to do with a woman who was found unresponsive. She had a gas stove on, thing that caused this presentation. That's all we know. So we have to fill in the gaps. What occurs from heating with a gas stove? Well, you get carbon monoxide poisoning. Okay, so that's very high yield to know. You get carbon monoxide poisoning. What does carbon monoxide do? It binds the hemoglobin with a much higher affinity than oxygen, and it causes hemoglobin to, whatever it's bound to bind very tightly and to not give it up. So it left shifts the curve. So we're going to try to find something that left shifts the curve. Let's read through our answer choices and find out. Choice A, increased temperature. No, we said that causes a right shift. Increased PCO2, also a right shift. Decreased pH, also a right shift. Increased physical activity, which realistically just increases temperature and increases acidity, both of which cause a right shift. And increased pH, which that one's causing a left shift. That's the exact opposite as answer choice C. So this is another point I wanted to bring up. If you typically see 2 answer choices that are the exact opposite of one another, most likely one of them is correct. Okay, so that should hopefully help you narrow things down a little bit. So the answer choice is E, increased pH. Let's look at question 2. I want you to do this one on your own and then we'll talk about it. Okay, so we have an infant, 32 weeks gestation, presents with difficulty breathing, requires intubation in the ICU. Artificial surfactants administered, but prior to delivery, the ratio of lecithin to sphingomyelin was 1:3 in the amniotic fluid. Exam wants to know which cell type in the lung is responsible for this child's pathology. So, 32 weeks gestation is considered premature. The baby was given artificial surfactant, which kind of ruins a little bit of the surprise, but this is a classic case of what? What's the disease here? What's the pathology? If you're not sure what the pathology is, also read the next line, where it talks about the lecithin to sphingomyelin. Any sort of premature infant, you want to be a little bit cautious of the levels of surfactant. That's why this child received artificial surfactant, is because presumably it wasn't producing enough surfactant to be viable. And this is further evidenced by the ratio of lecithin to sphingomyelin, which a mature lung that's producing enough surfactant would have a 2-to-1 ratio. And you want to make sure that they say lecithin to sphingomyelin. Some exams flip it. They try to trick people because some people just know the 2-to-1 ratio and they don't remember which one it correlates to. So lecithin 2, sphingomyelin 1. So they want to know what cell type is responsible for this pathology. So if he's not making surfactant, what cells make surfactant? Okay, you should be familiar with type 2 pneumocytes. They are essentially the regenerative cell in the alveoli. They could differentiate into type 1 and type 2 pneumocytes. They're able to help the lung recover from any sort of illness or some sort of damage. And that still doesn't give us the answer. You have to know what the type 2 pneumocyte looks like. Quickly read through the answer choices and then I'll tell you. So type 1 pneumocytes are squamous cell, but we're talking about type 2 pneumocytes, which are cuboidal cells. And that does help because sometimes they show you like an electron micrograph or something along those lines. If they do show you that, you want to look for something called a lamellar body, or just look for a cuboidal cell. Let's look at question 3. So this is a bit of a longer question, so I want you to try the method that we were talking about. Read the last 1 or 2 lines, read through the answer choices, and then read through with a purpose the entire question and try to find keywords. So we have an elderly man who presents today with a productive cough that's lasted 4 months. Reports having multiple episodes over the past 2 years. Each episode lasted a few weeks or months. Examination of the lungs revealed diffuse wheezing and crackles with a blue tinge to the distal fingers. FEV1 is 60% of predicted. FEV1 to FVC ratio is 74% of predicted. Histological examination reveals hypertrophy of mucus-secreting glands in the bronchioles. And they want to know what other histologic finding would you see on biopsy. Keywords you should have chosen were productive cough, that's lasted for 4 months, and FEV1, that's 60% of predicted, which is low, and FEV1 to FVC ratio of 74%, which is low, and hypertrophy of mucus-secreting glands in the bronchioles. If you could, try to find what condition this is, and if not, then you have to resort to ruling out the answer choices, so let's do just that. Choice A, where do we see hyaline membranes and alveolar fluid? That's a hallmark feature of acute respiratory distress syndrome, also known as ARDS. And ARDS doesn't present with this, so it can't be answer choice A. Answer choice B, non-caseating granulomas. This could be from a few different things. It could be from a foreign body. It could be from sarcoidosis. Typically in the lungs, whenever they mention non-caseating granulomas, they really are hinting at sarcoidosis. But sarcoidosis presents with a restrictive pattern of lung disease. So what is restrictive and what is obstructive? Well, in restrictive lung disease, we expect FEV1 to decrease, we expect FVC to decrease, but we expect them to decrease at about the same rate, so that the FEV1 to FVC ratio is about normal or sometimes elevated. In an obstructive pattern of lung disease, FEV1 decreases way more than FVC, so the FEV1 to FVC ratio is very low, and that's an obstructive pattern. So this is an obstructive pattern, and that's seen in this patient, so it won't be seen with sarcoid. How about infiltration of eosinophils and CD4 positive lymphocytes? Anytime you see eosinophils in lung, you can think of a few different things, but one of them that should come to your head would be asthma or Church-Strauss disease or something along those lines, but it has to have some sort of like high eosinophils or atopia or something along those lines. We see no atopic signs here. How about infiltration of macrophages and CD8 positive lymphocytes? What would that be for? That would be chronic bronchitis, right? The bronchitis is just inflammation of the bronchi. With any inflammation, we have 2 phases, the acute and the chronic. If you remember from pathoma or pathology, acute presents with neutrophils and chronic presents with macrophages. So infiltration of macrophages would be one of the hallmarks for chronic bronchitis. Okay, in this case, the patient does seem to have that. Chronic bronchitis is an obstructive lung pattern disease. And you do get hypertrophy of mucus-secreting glands in the bronchioles. Okay, let's also just evaluate answer choice E for the sake of it. Necrotizing granulomatosis with polyangiitis. That's also known as Wegener's disease. That presents with a restrictive lung disease pattern. Okay, so that can't be the answer. So the answer to that question was choice D, infiltration of macrophages and CD8 lymphocytes. Let's check out the next question. So this is also a little bit long. I want you to try to practice the method here. So we're dealing with a 43-year-old heavy smoker, presents to clinic with worsening shortness of breath, occurred over the course of a few months. Physical exam shows a barrel chest dyspnea. So what does the barrel chest tell us? You have all this air trapped within your lungs and you can't get it out, which causes a barrel chest, also known as an increase in AP or anterior posterior diameter. This could be shown on radiograph a few different ways. They could show it through a sagittal cut where you just see that the anterior posterior diameter is much longer than the usual X-ray, right? You can also see it by looking at the diaphragms. If the diaphragm is pushed very low, then that means there's a lot of air trapped in there, and you can't get it out, so that's also indicative of an obstructive lung pattern disease. Percussion reveals hyperresonance. Auscultation reveals decreased breath sounds bilaterally. There is no evidence of hepatomegaly, icterus, or jaundice. So there's a reason they threw that in there, which we'll see in a little bit when we're going through the answer choices. What is the most likely diagnosis? Well, asthma technically is an obstructive disease, but this is a worsening shortness of breath over the course of a few months. So this is a consistent thing. This isn't an episodic thing, which is typically a hallmark of asthma, is if it's episodic. So we see Centriasanal Emphysema. There's also a Panasanal Emphysema in the answer choices. So we need to distinguish between the two there. So Centriasanal Emphysema is alveolar damage that's associated with smoking, while Panasanal Emphysema is associated with alpha-1 antitrypsin deficiency. So just a quick content review. Alpha-1 antitrypsin is created by the liver. It's in neutrophils and also macrophages. With alpha-1 antitrypsin deficiency, it's technically not a full deficiency in terms of absence in the body. It's just misfolded and can't be secreted. And its whole purpose is to block or regulate the activity of elastase, which breaks down elastin, which causes damage to the alveoli. However, alpha-1 antitrypsin builds up in the liver, which causes hepatomegaly, which can also lead to icterus and jaundice. So we know alpha-1 antitrypsin deficiency most likely cannot be the answer because of the last sentence, and since it causes a pan-acinar type of damage, E and D both cannot be the answer. So now we're between B and C. So for heavy smoking, with worsening shortness of breath and hyperresonance, it's typically a centriacinar damage. Bronchiectasis is technically obstructive, but presents with a productive cough that could be blood-tinged. So the best answer in this case would be B, Centriasanal Emphysema. Let's take a look at the next question. I want you to try to employ the method again here. So we highlighted some keywords, namely blood-tinged sputum, the ulceration near the middle concha of the right nostril, the urinalysis that detects hematuria, and that the patient's creatinine is 1.7. So basically what's been hit has been the nasal or nasopharynx, the lungs, and the kidneys. And that's a classic triad for one particular condition, which you should know. So what's an additional finding of that one condition? Well, let's go through the answer choices. Answer choice A, hepatitis B surface antigen in the serum. So that could be a characteristic of hepatitis B, obviously, but it also could be a vasculitis, specifically polyarteritis nodosa. Polyarteritis nodosa typically spares the lungs, so you wouldn't have pulmonary symptoms, but you could have like GI bleeds and muscle pain. And the GI bleeds could either be melena or hematochezia, depending on which vessels are affected. But as this patient has lung problems, A is most likely not the answer. How about B? Linear IgG in the glomerulus. That's hallmark for Goodpasture syndrome. So Goodpasture syndrome affects both the lungs and the kidneys, but it has nothing to do with the naso or nasopharynx. Okay, how about C? Anti-neutrophil cytoplasmic antibodies, also known as anti-proteinase 3 in the serum. So this is also known as C-ANCA. And if you're thinking that this is the right answer, then you are correct. This is the right answer because this is granulomatosis with polyangiitis, also known as Wegener's disease. And Wegener's disease is the classic triad of some sort of nasal or nasopharyngeal lesion with a lung lesion and kidney problems, right? And if you want to be a gunner, you can also memorize the fact that next to congenital syphilis, granulomatosis with polyangiitis, aka Wegener's disease, is one of the only other causes of saddle nose deformity. Let's just evaluate choices D and E, just for completeness sake. Choice D, eosinophilia on white blood cell differential. That can be a few different things, but this question is going according to the vasculitides. It's probably talking about Churg-Strauss disease. So Churg-Strauss is a small vessel vasculitis, similar to granulomatosis with polyangiitis, but it has eosinophilia. It does not affect the nasopharyngeal passageway, but it does cause a foot drop or a wrist drop or some other neurosymptom, along with high eosinophils, which is not seen in Wegener's. Churg-Strauss also is a P-ANCA vasculitity. So some high-yield things to know about P-ANCA is it's an antibody against the myeloperoxidase, or MPO, in neutrophils, and there's only a few conditions associated with that. So while C-ANCA is associated with granulomatosis with polyangiitis, or Wegener's, P-ANCA is associated with Churg-Strauss, microscopic polyangiitis, and primary sclerosing cholangitis. An easy way to remember that Churg-Strauss is P-ANCA is to think that you chug your pee. That you chug your pee. Right? P-ANCA. P for P-ANCA, chug for Churg-Strauss. Then choice E, IgA deposition in the glomeruli. Well, that's just talking about IgA nephropathy, or Henoch-Scheinlein purpura also, which is associated with Buerger's disease, which is IgA nephropathy. But that would only affect the kidneys. You might have a bit of a rash if it's full-blown Henoch-Scheinlein purpura, but there's no pulmonary or nasopharyngeal passageway symptomatology. So the answer choice is C, anti-neutrophil cytoplasmic antibodies. Okay, this next question is super, super high yield. So definitely try to do it on your own. If you want, feel free to pause me, feel free to mute me, and rewind the video whenever you have your answer. But let's tackle this one together. An African American woman. So whenever you see a demographic, you should put it in your mind mentally somewhere. So an African American woman presents with shortness of breath, fever, joint pains, and a dry cough. Chest x-ray reveals bilateral hilar lymphadenopathy along with interstitial infiltrates. Pulmonary function test demonstrated normal FEV to FVC ratio. It is determined that angiotensin-converting enzyme levels are elevated. What would a histologic slide of the lungs show? So you probably have already been exposed to this type of question already. I just wanted to beat it into you. This is super, super high yield for respiratory. This is one of, if I had to choose 5 things, this is one of them that always shows up on boards. One thing you should note is that the patient has a dry cough. She's African American with bilateral hilar lymphadenopathy and a normal FEV to FVC ratio, which either indicates normal lung or restrictive lung disease. And since the patient's having lung problems, it's most likely not the former, it's probably restrictive lung disease. So what's a restrictive lung disease that causes a dry cough and bilateral hilar lymphadenopathy? Well, in case you didn't know, it also increases angiotensin-converting enzyme, and it's not mentioned here, but it increases calcium. And I'll go into the mechanism once we get to the answer. Alright, so let's talk about the answer choices. Choice A, non-caseating granulomas. What's that for? Like we said before, it could be foreign body, it could be sarcoidosis. What are some other symptoms of sarcoidosis? Well, if you're telling me high angiotensin-converting enzyme level and high calcium, along with a restrictive lung disease and bilateral hilar lymphadenopathy, yeah, you're correct. It's 100% sarcoidosis. How about let's just go through the rest of the answer choices, just for completeness sake. What are ferruginous bodies associated with? You should be saying asbestos right about now. How about diffuse alveolar damage? That's ARDS, ARDS. How about Cushman spirals? That's asthma. Right, that's the sputum that comes up. How about Burbank granules? We actually covered this in the last video. That has to do with Langerhans histiocytosis, right? Burbank granules are only found in Langerhans cells, which are modified dendritic cells. So I just wanted to quickly cover why sarcoidosis causes hypercalcemia. That's because any sort of granulomatous condition, granulomas are formed by epithelioid histiocytes, also just known as activated macrophages that fuse together to form a granuloma. Well, when activated by helper T cells, right, Th1, that's the thing that causes the granulomas, you have an upregulation of 1-alpha hydroxylase activity. And that's actually the last step in vitamin D synthesis pathway. So you're going to have active vitamin D circulating in high amounts, which brings in more calcium and phosphate from the gut. So that's why it causes hypercalcemia. Let's look at the next question. I want you to do this question on your own, and then I'll show you the answer, and then we'll talk about it. Okay, so the answer is E, defective ion channel. So what's the condition? Well, whenever you see recurrent pulmonary infections, especially from childhood, I want you to start thinking cystic fibrosis versus primary ciliary dyskinesia. So they actually both present with infertility, but for different reasons. So primary ciliary dyskinesia would be a dyneem arm defect. So that would be answer choice B. But the infertility for that one is actually due to the dysfunction of the dynein motor protein and cilia, which are found in the seminiferous tubules of the men and in the female reproductive tract. In men, you need functioning cilia in order to help move the sperm to the epididymis, where it finalizes its maturation. If you don't have that, the sperm don't mature, but they will be present. They're just not mature. In females, cilia actually helps push the sperm up further into the female reproductive tract. So naturally, if those aren't functioning, you have less of a probability that the sperm will make it to the egg, and fertilization will most likely not occur. Infertility in CF patients is actually completely different. In a male cystic fibrosis patient, there's a high correlation with absent seminiferous tubules, completely absent, so no sperm will be present. So that's the cause of infertility in cystic fibrosis, and that's an important association to make in your head. So what's with this whole fecal fat content thing going on? Well, in cystic fibrosis, you have clogging of the bile ducts, essentially, clogging of all these different ducts, clogging of the airways, the air passages. So you have clogging of a lot of things because the chloride channel, which is the CFTR protein, right, thing that's messed up in cystic fibrosis, that's not functional. So you're not able to pump chloride out, which means you're not able to pump out sodium and water, which means now the mucus that's already secreted is thick, so it will clog any sort of tubular structure, and that's what happens especially with pancreatic secretions, liver secretions, etc. So in order to break down fat, you need all these different enzymes from all these different organs in the GI tract. You need lipase, colipase, bile acids, bile salts, etc. And if you're blocking all these ducts, you're not going to be able to push that into the intestine, and thus you're not able to actually absorb and break down the fats and everything else. So another tricky way they could present this is actually, instead of giving you the fecal fat content, they give you a symptom of one of the fat-soluble vitamin deficiencies. Right, so they could say prone to bleeding, right, vitamin K deficiency, or night blindness, vitamin A deficiency. So just keep that in your mind. That's another form that they could present this in. As for the other answer choices, A, late complement deficiency. What are they trying to get at with late complement deficiency? Increased Neisseria susceptibility, right? Neisseria has a very thin membrane, which makes it highly susceptible to MAC complex, right, the membrane attack complex. The MAC complex is only formed from completion of the complement cascade. How about glutathione deficiency and oxidative stress? Well, they're pretty much one and the same. The most common cause of glutathione deficiency is a G6PD deficiency or glucose 6-phosphate dehydrogenase deficiency. And in that case, you can't make NADPH, which is necessary for glutathione to function. Glutathione basically just protects against free radical damage. Pretty much all you have to know. If you're deficient in it, you're going to have a hemolytic anemia, especially with oxidative stresses such as infection, fava beans, or naphthalene. Okay, and just to be very complete and thorough with our talk about cystic fibrosis, you should know already that it's an autosomal recessive frameshift deletion mutation in the exon 508 phenylalanine. And if you want to be even more of a gunner, you can know that the most common variant of this, the most common form of cystic fibrosis, is due to misfolding of the CFTR transporter in the rough endoplasmic reticulum. So just a quick biochem background, everything that gets glycosylated, everything that is destined to go to the membrane or to be exocytosed into the extracellular space goes through the rough ER. So this next question is very high yield, so try to come up with an answer using the method that we were talking about before, and we'll go over it together. We have a patient who's a schizophrenic, a 60-something-year-old woman who came in with hallucinations and she was restrained with haloperidol. She has a 30-pack-year smoke history. A few days later, she becomes tachycardic and complains of sharp left-sided chest pain that is worse with inspiration. Anytime you have chest pain that's worse with inspiration, it's called pleuritic chest pain. Imaging is done, which confirms the diagnosis. Which of the following steps should be taken next? Now, typically, step 1 doesn't really test the next best step kind of question, but this one is actually very, very high yield, and so they do test it. So what's going on with this girl? If you're saying pulmonary embolism, you're correct. So what would be the next best thing to do? Do you want to discontinue the haloperidol? Do you want to begin treating with a beta blocker, begin broad-spectrum antibiotics, start IV heparin, or do you want to wait? How did she get the pulmonary embolism in the first place? Well, we have some clues, right? She smokes, which damages the vessel walls, right? That's part of Virchow's triad. Endothelial cell dysfunction or disruption increases the chance for clot to form. She was also restrained with haloperidol. So if you're not moving, you don't have normal venous return to the heart, because, right, venous return is largely due to muscle and gravity. So already 2 things of Virchow's triad: increased venous stasis, or just in general increased blood stasis and pooling, as well as endothelial cell dysfunction due to the smoking. Both are risk factors for DVT formation, and DVT formation leads to embolism, and specifically, most commonly, pulmonary embolism. So what do we do to treat this? Well, for DVTs, we want to anticoagulate. So you want to start IV heparin as soon as possible. If you do see thrombolytic therapy, that's typically reserved for very, very large saddle emboli. Even if you do have multiple pulmonary embolisms, you don't want to thrombolize. You want to address the DVT with anticoagulation, and those clots will resolve on their own. But in general, for DVT, you always want to start IV heparin right away. Okay, and this is the last question for this video, so please read it over, and then we'll talk about the answer choices. Alright, so we have a 19-year-old woman who is known to be a heavy smoker for the past 6 years, presents to the emergency department complaining of sudden onset of unilateral pleuritic chest pain, accompanied by shortness of breath. Her family history is unremarkable for any medical illnesses. There was no preceding trauma. She's a tall, thin woman in moderate distress. Auscultation reveals decreased breath sounds over the right lung fields. Radiograph is seen on the right. Just for those who aren't really familiar with seeing or looking at too many radiographs, you want to have symmetry on both sides. That's one of the first things you look at. First off, you want to know what's left and what's right. So the right side of the picture is the left side of the patient. The left side of the picture is the right side of the patient. You do see an arrow, and the arrow is pointing to some sort of mass. That's actually the lung parenchyma that's been bunched up. The dark black spaces around it is just air, so air appears as black translucent areas, especially on X-ray. So it seems to be that there's air trapped in the right side of the patient and a collapsed lung. Okay, so this is a pneumothorax, and they're asking what findings would you have? So vesicular breath sounds, what do we think about that? No, not really. You would have just decreased breath sounds, right? Vesicular breath sounds and bronchial breath sounds are relatively normal breath sounds depending where you're listening. How about hyperresonance on percussion? Yes, you hear hyperresonance whenever there's an accumulation of air, right? You hear it over the gastric bubble, you hear it over a pneumothorax in this case, so that has to stay as a possible answer. How about C, increased tactile fremitus? Now, the only time you really see increased tactile fremitus, especially on boards, is with a lobar consolidation, so a lobar pneumonia. How about choice D, tracheal deviations away from the affected lung? That's usually more hallmark of a tension pneumothorax, and tension pneumothorax occur after a trauma has usually happened. In this patient, however, she has no preceding trauma. She was known to be a smoker, and she's tall and thin. These are all risk factors for a spontaneous pneumothorax, and the most common cause of a spontaneous pneumothorax is rupture of subpleural blebs. That's very high yield to know, subpleural blebs. There's not really too much tracheal deviation with subpleural bleb rupture or spontaneous pneumothorax. Sometimes you'll see it go towards the affected lung, but that's not a rule. It could be midline or it could be towards the affected lung. It's just never going to be away from the affected lung. So that means this answer is B, hyperresonance on percussion. And that concludes this section on respiratory questions. If you have anything that you think I missed or you want me to speak on something in particular, there will be way more questions. I'm just trying to do a baseline of everything right now, just to get all the high yield concepts nailed down for you guys. But feel free to leave anything in the comments, constructive criticism, anything. Please subscribe, like, and comment on this video for the YouTube algorithm. It really does go a long way to help me push out this content for you guys. Thank you for joining me, and I'll see you in the next episode of QuickSTEPs.